اهلا بيكم في المونثلي ميتنج بتاعت الايجيبشن ايفيتس ستادي جروب. احنا معاكم مبسوطين ان احنا قادرين نكمل لحد دلوقتي، ومعانا سبيكرز الحقيقه يعني جينيرس جدا ان هم يبقوا معانا continuously، سواء هم اللي بيتكلموا او بس بينريتش الدسكشن. هنبتدي النهارده مع دكتوره دينا بدار. دكتوره دينا بدار يعني قبل ما تبقى من الاميننس اوف uveitis in Egypt والعالم كله، هي a very good friend and يعني a very good support لأي حد بيطلب مساعدة في الuveitis. السبيش بتاع دينا النهارده قد ايه هي مهمة. ممكن تبقى very basic، بس مفيش حد هيعرف يشتغل uveitis غير لما يبقى عارفها كويس قوي، ومتأكدة انها هتبقى بالنسبة لنا مش زي اي مرة سمعنا فيها الريتينايتس. اتفضلي يا دينا.
ميرسي يا مي، ميرسي على التقدمة. أشكر. أوكي. ميرسي على الدعوة الكريمة. يشرفني ويسرني إن أنا أبقى معاكم. ميرسي يا مي، ميرسي يا دكتور محمد على ال continuous education activity. هنبتدي بقى على طول، بسم الله. أوكي. أوكي، باين عندكم؟
اه، باين.
very good. أوكي. طيب. اوكي، انا اسمي دينا بدار. انا بشتغل يوفيتس بقالي شويه في مصر، وكمان بشتغل ميديكال ريتنا وايميجينج. هنتكلم، دي الاجنده بتاعتنا النهارده، ان احنا هنتكلم على المالتيبل ديزيز اللي بتعمل ريتينايتس، وهنحاول ن identify each disease pattern and identify key imaging features. So what is retinitis? Well, retinitis is inflammation of the retinal tissue, صح؟ When we see retinitis, immediately this patient has posterior uveitis. So whether a patient has بس posterior uveitis أو معاه cells في الهايلويد أو في الانتيريور segment، على حسب بنسمي. لو طبعا زي ما احنا عارفين anterior segment is anterior, hyaloid is intermediate، و retina is posterior، ولو كله بنسميه pan. طيب الريتينايتس ممكن يجي لوحده، وممكن يجي معاه ريتينو كورويدايتس، وممكن يبقى نيورو ريتينايتس. واحدة واحدة. أول حاجة صورة هوريها، دي صورة من على الإنترنت، بس هنتكلم فيها في الآخر. It's just a quiz علشان تفتح عينينا. دي صورة ريتينايتس في البريفري اوف ذا retina. طيب، واحدة واحدة. أهم حاجة هو الفيرال ده لما بيدخل علينا العيادة نقوم كده وإيه، نبقى مهتمين وإيه، خايفين. في نوعين كبار من الفيرال ريتينايتس، وهنا حطاهم جنب بعض عشان نقدر نفرق ما بينهم: السي ام في والاكيوت ريتينال نكروزز. الاكيوت ريتينال نكروزز اللي هو بيحصل من اي herpetic disease other than السي ام في، والسي ام في is just the cytomegalovirus. طيب الشكل بيبقى ايه؟ تعالوا نمسك واحد واحد. السي ام في بيبقى شكله ايه؟ بيبقى شكله wedge shaped with an advancing edge. الويدج ده الايبكس بتاعه، البيك بتاعه رايح towards الاوبتيك نيرف دايما، والادفانسنج ايدج advancing للبريفري. markedly الفيتريس is very clear، واحنا شايفين هنا كل الديتيلز بتاعت الفيتريس، و amenable to imaging، وده بيحصل في patient immunocompromised. عكس الاكيوت retinal necrosis بيبقى peripheral، بيعمل circumferential spread، يعني spread بتاعه حوالين الكلوك hours بتوع الشبكية، وممكن ما نعرفش نصوره، وبيحصل في الاميون competent patient. ده لما بنعرف بقى ناخد عليه كاتس. لاحظوا الكاتس صعبة ازاي في الاكيوت ريتينال نيكروزس، وتعتبر سهلة شوية في السي ام في ريتينايتس. احنا بنلاقي ايه؟ بنلاقي في السي ام في ريتينايتس بنلاقي الكافيتيشنز دي، وبنلاقي زي بيلرز طالعة من الاوتر ريتنا داخلة في الميدل ريتينال لايرز، بلس اور ماينس ريتينال اديما، بلس اور ماينس سب ريتينال فلويد. طب نتكلم في الهرباتيك. لو قدرنا ناخد صور، لو قدرنا ناخد صور هنلاقي شوية تغييرات على في الريتنا نفسها، وهنلاقي سيلز كتير في الفيترس. وطبعا التغييرات دي بتبقى اللي هي الهايبر ريفلكتيفيتي، كومباكت هايبر ريفلكتيفيتي سبيرنج الار بي اي تحتها بيبقى كويس وكونتينيوس، وممكن تبقى كذا سيجمنت. طيب الليجنز بقى اللي مش هقدر اشوفها بالاو سي تي، طبعا دلوقتي في ادفانسمنت في الاو سي تي، وفي الوايد فيلد والالترا وايد فيلد ايميجينج، ودي صورة من الليترشر. لو قدرنا نشوف ممكن نلاقي معاها سكيسز، وبتلاقي ان الريتنا فرايبل، ودي حاجة من الحاجات الكومن جدا انها تحصل زي ما هنتكلم. طيب انا ممكن يدخل عليا عيان ابقى انا مش عارف هو كان ايه اللي حصل، بمعنى عنده حته هيلينج وعنده حته اكتف، وعشان كده انا كاتبه الهيلينج في في كل حاجه احنا هنبص عليها النهارده. نتكلم على الهيلينج سي ام في اللي هي الشكل ده. بيبقى الشكل ايه؟ بيبقى الريتنا ثيند وكولابست وفيها دريل، يعني مش قادر اشوف اللايرز كويس، وبس ستيل الار بي اي حلو. طبعا الاوتر ريتنا برضو بتبقى افكتد. طب لما ابص على العيان كلينيكلي بشوف ايه؟ بشوف السكارينج ده بيبقى towards البوستيريور بول، وممكن يبقى الريجريسنج ايدج اللي هو towards اللي جاي towards البارس بلانا او anterior للايكويتر. طيب ايه تاني ممكن اشوفه؟ اللي ممكن اشوفه هو لو عندي او سي تي انجو، بشوف ان الريتنال فيسلز are completely blocked زي ما احنا شايفين، وممكن اشوف ار بي اي اتروفي، او اشوف الليجنز واخده well defined edges. برضو حاجة من الحاجات اللي بتحصل كتير في الفيرال ريتينايتس when they heal ان هما they get what we call sometimes immune recovery uveitis، ان هو بيحصل outpouring للليمفوسايتس والبوليمورف لوكوسايتس في الهايلويد، فبتعمل هيزنس بلس اور ماينس، ان بيحصل thinning في الاوتر ريتينال لايرز في البريفري، ومعاها راتل ديتاشمنت. الراتل ديتاشمنت ده ممكن يفضل inferior و وات يعني طبعا لو هو inferior ممكن يفضل كده وما يعملش total retinal detachment، والعيان ده I've had this patient for years and years، وبيتابع معايا watching شوية ال detachment ده، ومش مش بنعمل له حاجة. طيب نتكلم في الحاجة التانية اللي very very common بنشوفها، اللي هي التوكسوبلازموزوس كوريو ريتينايتس، وتلاقوني كاتبة الكوريو بالكبير والريتينايتس بالصغير. ليه؟ عشان ده بتعتمد على الباثولوجي بتاعت المرض. تعالوا بقى نتكلم. الكلاسيك تيتشنج اللي هو هيدلايت ان فوج. يعني ايه؟ يعني عربية جاية في وشي والدنيا شبورة، وانا مش شايف من العربية دي غير شوية البياض بتاع النور بتاعها. ده بالظبط الشكل، ان احنا شايفين نقطة نور بياض في وسط هيز وسيلز كتير وانفلاميشن، وممكن نلاقي النقط دي اللي هي بتبقى عاملة زي الكي بيس كده بس جوه الفيتشر. طيب لو قدرنا ناخد تاني اجان، لو عرفنا نعمل صور الاو سي تي نبقى هايلين. طب الصور الاو سي تي بتورينا ايه؟ دايما بقول ان احنا هنبص على الهيت ماب. طبعا في ريتينال فاسكولايتس، وفي ريتينال كورويدال ثيكنينج. ولو اخدت كات بالظبط على الليجن هشوف الكورويد بفاقد الفيتشرز بتاعته، مش قادر اشوف الفيتشرز بتاعت الكورويد مع الريتينال افكشن بلس اجين اور ماينس ريتينال اديما، عاده بيبقى فيها ريتينال اديما. طيب اجين هنحط الاتنين جنب بعض، هنقول ده الفيرال وده التوكسو. من الحاجات المهمة جدا هي السيلز. التوكسو الاكتيف زي الاكيوت ريتينال نيكروزس معاه سيلز. السي ام في ده عيان عنده اميونو كومبرومايز، فمفيش سيلز كتير. الهايبر ريفلكتيف فيرتيكال ستريبس اللي احنا كنا بنتكلم عليهم اللي موجودين هنا، دول مش موجودين في التوكسوبلازموزس. هايبر ريفلكتيف اوفال ديبوزيتس اون ذا ريتينال سيرفيس، الديبوزيتس اللي قاعده على الريتينال سيرفيس اللاكني، ان الريتنا بتبقى بتعمل لاكني في النص، like it collapses and makes those hyper reflective لاكني. ودول الكلامس اللي احنا بنتكلم فيهم. وطبعا شايفين الكورويد هنا، الكورويد is markedly affected، ال RPE is affected as well. دي عيانة عندها الليجن دي فوق الديسك على طول. هل دي الليجن الوحيدة؟ لا. الكلاسيك تيتشنج هو ان الليجن الاكتف تطلع جنب الليجن الانكتف، ولكن في الحالة دي it was interesting لان هما مش جايين جنب بعض. so الليجن الاكتف عند الديسك والانكتف جاية في البريفري. طيب sometimes بقى ايه للأسف بيحصل يعني الموضوع ده ان هو بما ان احنا we're breaching الكورويد و breaching البروكس membrane، ممكن يطلع neovascular membrane, macular neovascular membrane to complicate an old scar. This is a patient that as soon يعني this is a single eyed patient، وأول لما جت على طول بالنيوفاسكولاريزيشن. عرفت ازاي؟ عرفت كمان حتى كلينيكلي بالهامرجز دي وبالسب ريتنال اديما الكبيره. لكن لما عملنا او سي تي انجيوجرافي، ودي الحاجات القليله اللي انا هستعمل فيها الاو سي تي انجيوجرافي الصراحه، لقينا النتورك دي. طيب what about الهيلينج؟ زي ما احنا اتكلمنا ممكن يجي لنا هيلد ليجن. الهيلد ليجن again بتبقى سكار، بتبقى اصغر جدا في الحجم، وبتفقد كل الفازينس، وبتبقى much well demarcated زي هنا. طبعا plus or minus pigmentation، يعني مش لازم دايما تبقى pigmented. ولو عملنا OCT عليها بنلاقي ان الكورويد والريتنا رجعوا في مكانهم، بس الاتنين متأثرين والار بي اي. الباسل ديزيز حاجة من الحاجات اللي احنا بنشوفها كتير في عيادتنا، بس فيها شوية اوفر كول. احنا فاكرين ان احنا بنشوف باشا كتير، باشا موجود طبعا اكتر من بلاد بره، بس خلينا نتكلم عنه واحده واحده. الباشت انا دايما اقول للعيان الباشت ما يجيش يتسحب، الباشت يجي فول بلون. الباشت يجي بريتينايتس again respecting ال RPE respecting ال RPE affecting all the layers of the retina. These layers we cannot bring them back. هما they're infarcted they've lost all the architecture. ده شكل الباشت. طبعا you can see برضو the amount of haze that's affecting الباشت، ومعاه retinal vascular affection. طيب ده دايما بيجي في السنتر؟ لا، باشا تيجي في المكان اللي يريحه. وهنا البيشنت ده كان جاي معظمه في البريفري، سنتر تقريبا ما فيهوش حاجه. ال الشكل الفاسكولار اوكلوجنز اللي هي على الليفل بتاع الكابيلاريز، ومعاها البالب النيو فيسلز دي، وشويه تلانجكتاتيك تشينجز. كل ده بيقول لنا الكرونيسيتي اوف المرض. دي كانت عيانة أول لما جات لي بالشكل ده، اللي هو frosted branch angiitis و retinal infarction. When she healed and she healed nicely الصراحة. when she healed and we could regain vision in this eye to an extent. بنعمل ال OCT angiography شفنا إن الماكلة is affected زي ما بقول لكم infarction and it's gone. زي ما قلنا برضو هنحط السي ام في قدام الباشت. طبعا الهيز حاجه من الحاجات المهمه جدا، لان السي ام في ممكن يجي في السنتر. الاكيوت ريتال نيكروزس ما يجيش في السنتر، فبنتكلم في السي ام في. السي ام في الهيلينج بتاعه احسن شويه، forgiving شويه، ولكن في البهشات للاسف مش بيبقى forgiving. طيب نتكلم في البهجات. ولما الهيلينج ايه اللي بيحصل؟ زي ما شرحت لكم هيسيب حته سكارينج، بس احنا شايفين سوري حته تيننج، لكن احنا شايفين بتاع بتجري sorry about that. احنا شايفين layers. we can tell the layers they're thinned, they're compact, and they've lost some of their demarcation, but not as bad as viral. بس لو عملنا OCT and geography we can appreciate the amount of ischemia. So it depends، neglected case، severe case، ولا well managed case. آه ده ايه؟ ده الفنجل is more of a chorioretinitis. بس it's worth mentioning ان هو بيعمل ال subretinal abscesses دول، وكلاسيكلي طبعا بيعمل في الفيترس، بيعمل ال string of pearls. ممكن يجي بشكل ايه؟ دي كانت بيبر مجمعة كل الاشكال اللي بيجي بيها الفنجل ريتنايتس. فممكن يجي بريكنج من الكورويد داخل على الاوتر ريتنا، وكمان واصل للانر ريتنا. وممكن يجي افكتنج الانر ريتنا والهايلويد ويعمل الريترو هايلويد thickening ده. وحتى when it heals ويفصل بيفضل thicken. ممكن يجي في صورة الابسس ده، اللي هو احنا we really can't tell if it's coming from the choroid, but it doesn't look it's actually affecting الريتنا والهايلويد فوق الريتنا with marked inflammation massive inflammation. او ممكن يجي بسكيسز في الريتنال layers. ده الشكل اللي بيجي بيه الفنجل. طيب في حاجة بقى احنا بنشوفها شوية اكتر دلوقتي في العيادات، بسبب ان احنا بنشوف اكتر ناس من سب سهران افريكا. دي حاجة اسمها ريفت فالي فيفر ريتينايتس. دي مش صوري، دي صور دكتور يوسف فؤاد. ده بيبقى الشكل ايه؟ طبعا احنا we can see اولا ان مفيش هيزينس خالص، مفيش هايلايتس، مفيش intermediate uveitis، في retinal infarctions، ومعاها marked retinal arterial affection. الارتريز almost white وهنا الفيلينج بتاعها مش كويس خالص في الانجيوجرام، with markedly staining. وطبعا شايفين الانفاركشن في الفاز لما نعمل على الصور sorry about that. لما نعمل ال OCT بنشوف ان هي شكلها شبه ال artery occlusion because all the retinal layers are affected، بس ال RPE is still intact. ولكن طبعا مع الافكشن مع الانفاركشن بيحصل cavitation. نرجع بقى تاني للصورة دي. فاكرين الصورة دي ده ايه؟ دي التروما. التروما بتعمل الشكل ده it's called retinitis scleroptica I think. دي تروما as you can see. في هنا retinal detachment probably choroidal affection برضو، وجنبها بتعمل retinitis. فلما نشوف برضو peripheral retinitis ممكن نفكر في تروما ونبص more peripheral. So الكي بوينتس اللي انا حاولت اقولها النهارده ان احنا ان identify الباترنز بتاعت كل ديزيز بيعمل الريتينايتس، وازاي نستخدم الايميجينج لخدمتنا. Thank you very much and I'm happy to take any questions.
اوكي يا دكتورة دينا، يعني حاجة صراحة ممتازة. آه، في حد عاوز يسأل حاجة؟ طيب.
Okay.
كان اي اسك انت حضرتك قلتي الريتينايتس بتاعة التوكسوبلازما بيكون فيها كرويدال انفولمنت اكتر كده.
Yes.
اوكي. انا كان دايما under the impression ان هي mainly retinitis rather than choroiditis. This is new for me يعني.
So so هو المفروض ان التاكيزويز بتيجي وتقعد في الريتينال فيسلز، بس الانفكشن بيحصل كورويدال وفوقيه ريتينال انفكشن.
طب
Thank you very
دينا،
much.
عشان ده السؤال اللي هيبقى في ذهن الاودينس، سبيشالي الشباب اللي لسه بيبتدوا يفاتس، وحتى احنا كلنا بنبقى بازل بيها شويه. اوقات العيان بيبقى فيري ستريت فورورد، مثلا عيان هيز نون بشاتس، عيان اميونو سبريسد، فانت متخيله ان ده فايرال. اوقات العيان بقى ما يديكيش اي كلو من الهيستوري، وتبقي قاعده والله شكله يدي كذا، بس شكله يدي كذا، مش عارفه تبتدي في العلاج ازاي. في الوضع ده بقى انت عامله يعني ستابس معينه في دماغك بتمشي، او الجوريزم انت بتعمليه، ولا في انفستيجيشن؟ انا في انفستيجيشن بحب اعملها لو في اغلب الحالات لما ببقى بازلد، بس يعني خليني اسمع منك الاول.
اوكي، انا هقول الكلمه اللي انا سمعتها من دكتور احمد سلام، الباترن ريكوجنيشن ان يوفيتس. ده اول كلمه انا سمعتها من دكتور احمد. تاني كلمه برضو انا سمعتها كانت ان الفيرال مش فورجيفنج. الفيرال بوش سيستميك لو انت شاكك، وطبعا think about tapping و injecting on the day next day maximum. ده اكتر حاجه بتخوفني هو الفيرال. طب how can I recognize الفيرال؟ طبعا الهيستوري بيبقى صعب جدا، وانا متفهمه ان العيانين ساعات الهيستوري بيبقى صعب. الشكل، الهيز، الافكشن اوف ذا اذر اي، يعني صعب قوي ان انا الاقي acute retinal necrosis bilateral although I've seen it وموجوده more common than we think. اعمل ايه؟ I will side with viral. I will push antivirals. I will schedule for an AC tap, and I will not start systemic steroids. لان again انت بتفكري bilateral ولا unilateral؟ لو بتفكر bilateral فانا هفكر في باشت وافكر في bilateral arn اكتر. لكن لو يونيلاترال هفكر في السي ام في، والسي ام في ده ما بيتغلطش لان عاده العيان ليه باترن معين، يعني عيان اميونو كومبرومايز لعده اسباب. هفكر في توكسوبلازموزز، وهفكر في فنجل. فنجل عيان سكره مش مظبوط، كان لسه في عمليه، كان هوسبيتالايزد، كان الفنجل ليه شكل برضو في العيان. فاضل التوكسو والبهشت، هاخد او سي تي سكانز immediately.
هايل. يعني I agree totally. والتابنج ده يعني قد ايه بقى بيسهل الموضوع لما بقى available وبقى بيرسبكت ال very small samples that we could get، وبيخلينا نرسبكت الفيرال ونديله أهميته واحترامه قبل ما نبوش ستيرويدز ونندم بعد كده. في حد تاني عنده questions before we move to the next talk؟
طب انا عندي سؤال ليكي. انت
أنا
كنت انت عارفه
طيب.
الاجابه بس هتسمعيني الاول، قولي اجابتك.
اه التابنج. تابنج شوف بقى، يعني احنا دلوقتي لما بنعمل البايو فاير بيقدر يدينا الريزلتس within the same day or even يعني تاني يوم بالكتير قوي بكون عندي نتيجة. ف وبحقن انترافيترال انتي فايرال مع السيستميك، it would buy me 24 hours قبل ما يبقى عندي يعني ريزلت اللاب. وفي نفس الوقت لو حبيت ادي ستيرويد ما اتاخرتش قوي. فهو بالنسبة لي بقى رغم ان هو invasive بس it saves the eye يعني and maybe the patient sometimes.
very good انا agree. دكتور سلام، عندك حاجه حضرتك تحب تتعلق بيها؟
شكرا. برزنتيشن جميله دينا. لا لا، انا هغطي على شويه حاجات على الريتينايتس في السلايدز بتاعتي. وهو زي ما انتي قلتي اهم حاجه، يعني في رايي ان هو اليوفيايتس. لو هو حد قال لي ان الحاله دي توكسو، فانا هفتح الكتاب شابتر توكسو and then الموضوع سهل. هو بس الفكره ازاي نعرف ان العيان دي توكسو، العيان دي مش فايرال، العيان دي مش سيفلس. فهي دي النقطه في اليوفيايتس. انت بس قول لي احنا في اي شابتر، بعد كده الموضوع هيبقى سهل. I will put
وانت
lots of
قولي.
emphasis on the diagnosis.
هي
انا عايزه
دايما انهي شابتر دي هي المشكله والله. بس
بالظبط يعني
العنوان حضرتك، العنوان وبعد كده الكلام جوه سهل.
بالظبط. اللي هو بعد كده سهل جدا ان احنا نفتح الكتاب ونعالج العيان. فهو انا رايي ان في اليو في اس اهم حاجه ان الواحد يفكر في الديفرنشال زي ما كانت دينا بتقول. يعني انا شلت الالقاب يعني. فدكتوره دينا، فاهم حاجه هو الديفرنشال، وازاي يبقى في خطه للباترنز المعينه اللي هي بتبقى كتير. يعني باترن مثلا، يعني I'll show some cases. pattern بتاع retinitis، patterns بتاع vitritis، pattern بتاع احنا مش عارفين ايه اللي بيحصل. لازم يبقى في patterns معينه. وفي نفس الوقت انت بيبقى في ورك اب، وانت بتطوره كل شويه حسب المكان انت بتشتغل فيه، حسب انت بتشوفه، حسب الاكسبيرينس بتاعتك. ده رايي.
واضح ان حضرتك هتنريتش لنفس التوبيك اكتر. فليتس
ايه
موف.
الاخبار ايه الاخبار يا معي؟ ممكن اسال دينا سؤال سريع؟
طبعا ايمن نهري
ازيك
معانا عبر الاثير. منورنا يا ايمن والله، اتفضل.
ربنا يخليك. ازيك يا دينا؟ ميرسي على البرزنتيشن الهايله. كنت عايز اسالك دلوقتي بالنسبه للبي سي ار. يعني هل واجهتك مشكله، يعني لو انت عملتي اي سي تاب وبعتي بي سي ار، ان بيبقى فيه فوليوم ريكويرمنت معينه؟ لان مثلا هنا بيحبوا ان هو يبقى فيه لكل فاير بي سي ار هيبقى تيستد حوالي 0.3 mLs for each virus. فلو احنا مثلا هنعمل تاب، هل بتبرايورتايز التستنج على حسب الكلينيكلي او الايمجينج بلين towards ايه، ولا بس بتبعتي وخلاص الفول يعني بانل وهوبينج ان هو كله هيتعمل؟ شكرا.
تقلب انت المواجع، تقلب انت المواجع.
ايوه.
طيب خلينا، اوكي you wanna go in depth، ماشي I'm happy. بص بقى، انا واجهتني المشكله دي قبل كده،
مهم.
وواجهتني في حاجتين. واجهتني في ان هم قالوا لي not enough، بس العيان كان سي ام في ريتينايتس، ليمفوما، نون هودجكنز ليمفوما، بايلاترال، سوري توايس، عامل بون مارو ترانسبلانت توايس. فده كان سي ام في ريتينايتس، يعني walking talking سي ام في ريتينايتس. فحتى لما العينه ما
مهم.
طلعتش عالجت على انه سي ام في.
بالظبط، دي برضو نقطة تانية، ان عشان كده الايمجينج فايندنجز والكلينيكي ده it's very important. لان احنا في الاخر حتى لو عندنا الكابابيلتي ان احنا نعمل اللاب، ممكن ما تبقاش سامبل انف، لان احنا لو هنعمل اي سي تاب مش هنقدر نجيب كل الكمية عشان نتست لكل حاجة، كل الفيروسز وكمان التوكسو اكسترا. فعشان كده انا شايف ان البرزنتيشن it's very important على النقطة دي، ان احنا للاسف حتى مع اللاب يعني it's not that easy.
it's not that easy. هو دلوقتي
ايمن،
في
انتوا
حاجة.
بتستخدموا شركه ايه في المكان اللي انت فيه؟
احنا actually بنبعت centralized lab في ويسكونسن here ف I'm not sure لا يعني بنبعت المستشفى وبعد كده هما بيبعتوا lab I think في ميلواukee.
ان هو ممكن يبعتوا
بس
فيراكور. معظم الناس بتبعت لفيراكور. فيراكور are very good.
فيراكور اوكي
فيراكور
آه،
هايلين.
و
انت
و
بترتب اللي انت عايزه. يعني انت
مهم.
بتقول والله عشان هي سامبل صغيره. احنا we get يعني good results في even 0.1 مل من ال AC تاب. فبس
هو
بترتب بتقول رقم واحد مثلا let's say مثلا حالة دي توكس، ورقم اتنين بي زي في، رقم ثلاثة اتش
مهم.
اس في 1 and 2، رقم أربعة مثلا
مهم.
سي ام بي، رقم أربعة ابشتاين بار فيروس بس we stopped looking for it لأن هو بيلخبطهم وعمل
yeah
لهم مشاكل. فاحنا
yeah
بنرتبها.
اوكي
بس هم they deal with
yeah.
0.1.
يعني هم ما عندهمش مشكلة في الفوليوم they can test for the whole that's
هم they
interesting. لا
test
هنا
the order اللي
عندنا
انت حاطه.
اوكي لا هنا بيرفضوا يعني بيقولوا لي this is below the minimum
Yeah.
like recommended amount وبيبقوا عايزين يعني مش بيرضى يتست لكل الفيروسز فبضطر ان انا اقول له طب خلاص test for this وما بقاش عارف بقى طب الباقي نيجاتيف ولا.
Yeah.
اوكي نجرب فيرا كور حضرتك قلت اوكي.
طب هسأل انا
شكرا
بقى،
جزيلا.
هقول لك احنا هنا خبرتنا في مصر ان احنا اولا I try to flatten the AC as much as I possibly can which works انا
مهم.
كده I'm going to inject او I inject first and then I tap. فطبعا I flatten as much as I can. ودي حاجة. تاني حاجة ان احنا في مصر هنا بيشتغلوا بحتى 2 مللي، بنطلع لهم 2 مللي. الحاجة اللي
عشان
ابتدت
البايو فاير بالتالي مش يعني عمرهم ما واجهتني مشكلة الفوليوم دي في السي اس اف بايو فاير.
مهم. اوكي انا بس ما هو ده السؤال هل احنا بنعمل تيست هنا مختلف انا actually I don't know details لا ولا
البايو
هم
فاير
هنا بيحاولوا يمشوا.
multiplex PCR، هو اسمه كده multiplex PCR.
اوكي فهو هيتست كل حاجه بنفس الفوليوم يعني فمش يعني انترستنج ممكن
وفانجل، وفي شوية فانجل ويعني حاجات
اوكي
كده وبكتيريا. مش
هو
عارفة هو
2
نفس
يا
مللي
ممكن.
جرعة
السنسيتيفيتي،
كبيرة قوي.
هو نفس السنسيتيفيتي ولا بتختلف لو عملنا لكل فيروس لوحده. أكيد ممكن يكون ده مور سبيسيفيك، بس يعني بالنسبة
مهم.
لأزمة الفوليوم اللي احنا بنواجهها فممكن ده
مهم.
يبقى كومبرومايز مقبول شوية.
لا دي فعلا انا محتاج اسالهم ايه التست بالظبط اللي احنا بنعمله لو هو في امكانيات ان احنا نعمل بايو فاير. دي فكره حلوه.
دينا كنت هتقولي بوينت 3، أنا قطعتك، أنا آسفة.
Sorry, so which brings me back to the next point ان sometimes في عيانين يعني ممكن نتكلم في الموضوع ده بعدين، يعني اللي هم الهيستو اللي احنا سكتنا وقلنا ده بوز. انا مش
مهم.
مقتنعه ان ده انا مش مقتنعه ان ده هيستو.
هو
احنا
الهيستو ده
بنقول
it's a
ان ده
big
بوز.
mystery ده big mystery احنا عندنا برضه حالات هنا we label it as pose بالظبط. مم.
فاحنا دلوقتي في وجود التستنج اللي هو، ودلوقتي في مصر في even more testing هقول لك اسمه، وده موجود الميتاجينوميك سيكونسينج. الميتاجينوميك سيكونسينج ده موجود بره فور شور، بس انا ما اعرفش تكلفته كام.
مهم.
في الميتاجينوميك سيكونسينج ده بيجيب لك، هو بيستخدم في البلورال فيوجن والاسايتس وكده، في الحاجات طبعا العيانين اللي ما بيبقوش عارفين what they're dealing with. but احنا ممكن نستخدمه في العين. ف هبتدي افكر ان انا في العيانين اللي احنا بنقول عليهم بوز
مهم.
ما هذا. بس ما فكري بقى ان هو هل هيطلع في الاي سي تاب، هيطلع في الفيرال تاب، ولا دي حاجة جاية through the blood؟ ما اعرفش. that's just something to think
مهم.
about.
هو السؤال التاني هو ممكن يبقاش الاورجانيزم نفسه او الاورجانيزم نفسه اتس جون واللي فاضل هو الاميون ريسبونس ليه. فدي برضو يعني you'll exclude an active infection but آه مش ان هو الكوز الاولاني maybe. يعني I
مم.
think إن لازم to go back to the original testing اللي هم عملوه في الستايز اللي شخصوا بيه الكونديشن اصلا which I think اللي هو كان ايه اللي هو حاجه هيستو تيست كده اللي كانوا بيعملوا حاجه في يعني حاجة زمان قريتها مش فاكر كان ايه سكين تيست ولا كانوا بيعملوا ايه.
انتس كان فيه الهيستوبلازمين ده اخد تبركلين بس.
اه
ما اعرفش
كان
هو
انا
ده.
قصدي هم originally diagnosed the condition كده يعني لازم ترجعي بقى وتشوفي لان انت دلوقتي you're wondering اصلا if the condition is real or no صح؟
اه، ما
مهم.
مش كلنا كده، مش انا بس.
لا ما انا فاهم بس قصدي احنا يعني قصدي لكن هي already هم established it على اساس ان هو عشان كده presumed ان هم لو العينين اللي coming from a specific area testing positive for histo I think skin test على قد ما انا فاكر. وبعدين خلاص شخصوا الكونديشن. انت كده بقى عايزه تبصي في القصه من الاول خالص.
يا دكتورة رحاب بتقول إنها عندها مشكلة برضو same في Aberdeen trying to get SOP to avoid this problem. What is SOP يا دكتورة رحاب? Can you tell us? احنا we can move to the next speaker.
Standard
اوكي.
of practice. Standard of practice غالبا.
اوكي
أوكي.
اوكي صح you have a point. واضح ان الحمد لله انه مش احنا ب standards of practice absolutely. واضح.
طيب يعني واضح ان احنا لسه هيبقى عندنا more rich discussion لان دكتور احمد قال لنا ان هو هي cover something in this area. Let's go to talk of Dr. Ahmed Salam. Dr. Salam, as all of you know, he is an eminent professor at Jones Eye Institute, University of Arkansas for Medical Sciences. He is a figure in uveitis, medical and surgical retina, ocular inflammation and infection. Great researcher in these topics. And deeply involved in resident and fellow education. Currently serves as ophthalmology residency program director at University of Arkansas for Medical Sciences. التايتل او بتاعه التوك انترستنج جدا. انا قاعده من ساعه ما دكتور احمد بعتها لي مستنيه اعرف الكونتنت. فليتس اول سي بقى. اتفضل يا دكتور احمد.
اليوس انا شكرا جدا، متشكر قوي على الدعوه، مبسوط قوي ان انا اكون معاكم. وانا متابع الواتساب جروب، بس ان شاء الله اشارك اكتر باذن الله. وهايل ان يعني انتوا عاملين شغل جامد، وربنا يوفقكم ان شاء الله. انا بس فكرت ايه الحاجات، النقط المهمه في اليوفيايتس، وانا عارف ان ده يعني غالبا ميكس اودينس، يوفيايتس سبيشالست وريتنا سبيشالست وميبي جنرال ophthalmologist. I'll try to cover most of the important points in uveitis that I could think of. Please feel free to interrupt and stop me for questions. Maybe I'll كل شوية هقف ويعني نشوف لو عندكم أسئلة بحيث يبقى interactive. فخليني share ال presentation. ويعني دكتورة دينا made my life very easy لأن I'll be building on the things that she has beautifully mentioned. Okay, excellent. اوكي، هل شايفين البرزنتيشن بتاعتي؟
يس دكتور احمد اتفضل.
اوكي هي
شايفين.
اوكي. هو I think number one which is very important in يعني make sure ان انت you're not seeing the tip of the iceberg. So Dina beautifully covered the classification of uveitis, and I just want to give you a case to share with you. This case, this is a patient. Sorry. This is a patient ده عيان شفناه في انجلترا زي ايام زمان قوي قبل electronic medical records. You can see the stack of notes on the desk there. This patient was seen by a resident, and the patient vision 30-year-old fit and well Brazilian male coming because of just mild pain in the right eye, 6/6 vision, and then the other eye was an atrophic eye and no light perception since he was a kid, and he doesn't know really why he lost the vision in this eye or what happened. 2 plus cells and flare in the NT chamber. And then the resident made diagnosis of anterior uveitis, put the patient on prednisone drops, and told him to come back in a week, and did not dilate the fundus. And he thought, okay, well, anterior uveitis, no other things going on, vision is good. The next day, the patient came with more pain and blurred vision, and that's actually what we saw in this patient. So basically, what happened in this patient is he just only saw the tip of the iceberg, and he missed the retinitis at the back of the eye, and just diagnosed anterior uveitis. So very very important is you need to make sure, okay, what are you dealing with? Are you dealing with just anterior uveitis, or you're dealing with posterior uveitis, and there's an anterior uveitis? So now we're dealing with panuveitis. What exactly we're dealing with? And something very important, especially in new cases, always dilate both eyes, especially in new cases for uveitis, whether you think it's just anterior uveitis or not. My second point is the descriptors. So it's very important to be able to describe what you're seeing and put things together. For example, I mean, there was a nice point of discussion ما بين دكتورة دينا ودكتورة عبد العظيم about retinitis and choroiditis. So for example, the viral retinitis is usually retinitis, while toxoplasma is a retinochoroiditis. So the retina is involved, the choroid is involved to a certain extent, but this is different from actually chorioretinitis, which is the other way. You have more choroid involvement than retina, or you have choroiditis. And a good example of chorioretinitis is actually the fungal one, which is more of the choroid is involved, while toxoplasma is more of the retina is involved, and the choroid is involved to a certain extent. And while Dina was talking, I've actually found an OCT and I've put it in just to show this. So are we dealing with a choroiditis or retinal choroiditis or a chorioretinitis or retinitis? That's important because it limits the differential diagnosis. Also, if we're dealing with vasculitis, is the artery involved? Is the vein involved? So always you want first, like as if you're commenting on a picture, you want to describe and then try to put things together, as I'll tell you in a second. So here, for example, you have an area of retinitis, and next to a scar, you have arthritis, you have vasculitis involving the arteries. Some of them are actually like interrupted, and that's an important differential because you'll find that vasculitis involve the artery. There are only like 5 or 6 causes: toxo, syphilis, herpetic, something called Ivan syndrome, Suzak syndrome. So actually, there are only 4 or 5 causes, collagen vascular disease. So it limits the differential diagnosis so much. And that actually from a chapter that we wrote about was actually the book chapter was called Uveitis for the retina specialist. And here, for example, that's again more extensive retinitis, which what you see in advanced herpetic retinitis. The choroid is not involved in this case, and that's here you see there are more well delineated lesions and they are deeper, and that's what you see in choroiditis. So it's important to try to differentiate, is this a retinitis or a choroiditis? And OCT made it very easy, especially when you can get now even peripheral pictures on OCT. And that the vasculitis is artery, veins, both sides involved. So just describe and try to capture all the lesions and have details. Uh, the next point, which is also important, is meshing, and we'll discuss this further. So, for example, if I tell you there's a 24-year-old Caucasian female coming with unilateral, unifocal retinitis at the macula, from the history, she's immunocompetent, fit and well, and there's no high-risk social history. I mean, this is a very obvious story, even without the patient seeing the patient. That's a toxoplasma retinitis, like this. Right, but this is different. From example, if we're talking a male and there's like men having sex with men, and then you have this appearance here, that's again different. This is here, this is like most likely we're dealing with syphilis. So it's very important to describe, put things together, try to connect it, make like a story, and then it will be easy reaching to the differential diagnosis. The other one, which is important, and people who are into bodybuilding, they know the big three: squats and benching and deadlifts. So when you think of uveitis, always think big. So I wouldn't really worry if this patient has just inflammation or has sarcoid uveitis. It doesn't really change the management so much. What I want first is to try to fit the patient in one of these 3 groups. Are we dealing with inflammation, infection, or masculine? Or to be honest, it might be best to put it the other way. So first, you want to make sure this is not infection, right? And infection, we go bacterial, viral, fungal, protozoal. And that's with any uveitis anywhere. And the second, are we dealing with masquerade? Well, if not, or if we need to exclude it, then we're dealing with inflammation. And that inflammation can be undifferentiated inflammation, which is the more posh name or the better name for idiopathic, or part of systemic disease, which can be sarcoid or Behçet. And in a way, it doesn't make a difference, although it may make a difference. I'll tell you why. For example, if you have a patient with sarcoid uveitis, but no chest issues whatsoever, the pulmonology, they don't even want to see this patient. Again, if you have Behçet and there's nothing really going on from the history, fine, the patient has Behçet, but there's no involvement elsewhere. So at the end of the day, what you want to try to do is just put them in one of these 3 groups. If you know more details and if you can diagnose sarcoidosis, fantastic, you're doing great. Otherwise, it just does not matter as long as the system review is non-revealing. Yeah, so that's the next, sorry. Okay. Let me just give you a few examples, and maybe we can stop here if you have questions. So this is a patient coming with anterior uveitis, and if you can see, and if you can see this patient, actually was referred from an optometrist because of anterior uveitis not responding to treatment. And the optometrist sent me this patient and said, can you consider immunosuppression of this patient? Which is fine. I mean, sometimes anterior uveitis need even systemic treatment, but this is not common. But if you look here, again, you go with this mentality. Okay, we're dealing with uveitis. Is this infection? Is this masquerade? Or this is just inflammation, even for anterior uveitis? And two things here like caught your attention, or three things. First, the patient had persistent uveitis, which to the optometrist really was treated with prednisone for a long time. Second, the patient actually had the pressure was high and the patient has iris changes. And that just makes you think that this patient may have a herpetic uveitis. So in this situation, we tend to do AC tap, and that's very useful. And this patient actually had the HSV1 and did very well on valacyclovir for 2 years and a small dose of prednisone, and then she was able to stop everything. So again, take us to the same point we were discussing. Even for anterior uveitis, are we dealing with infection, inflammation, or masquerade, which can be neoplastic or non-neoplastic? And one of the most important things for infection in anterior uveitis is the herpes zoster or herpetic uveitis in general. So one thing here I just want to direct your attention to, when you're dealing with anterior uveitis, it's important to make sure that you're, again, not missing part of like a posterior uveitis, and you're only seeing that part of the anterior uveitis. So first, always dilate new patients. Second is, yes, it could be like an anterior uveitis not responding to treatment and you need to go up to immunosuppression, but this is unlikely. And make sure you're not missing something from the back. And the other thing, you're not dealing with an unusual type of uveitis that does not respond fully to steroid, like for example, Fuchs stereochromic uveitis, or like the cases herpetic anterior uveitis. On the left side of the screen is something very, very, very important in my mind. You have a patient coming with recurrent or what looks like a recurrent anterior uveitis, but when you go more into it, what's happening is that this patient has episodes less than 3 months from stopping the treatment. So you stop their treatment, they flare up again. And then they go for 2 months and then they flare up again. This is not a recurrent anterior uveitis, that's a chronic anterior uveitis. And the reason they are flaring up is because you're stopping their treatment. The best analogy here is like hypertension. You stop the antihypertension medicine, blood pressure goes up again. So these patients need to be on a long-term, low-maintenance treatment. Okay, I'll show you another case. So this is again another patient with significant anterior uveitis. You can see actually there's a bit, even a sliver of hypopyon there. So and he's really in pain. You can hear him here in the video. So again, we're dealing with anterior uveitis. We cannot see the back of the eye, right? So the next step to do is a B scan. And the B scan was normal. There's no vitreous involvement. So we're dealing with very fiery anterior uveitis. And you have here hypopyon. So you want to make sure, okay, are we dealing with infection? Are we dealing with inflammation, or we're dealing with masquerade, right? So that's, again, the important differential. And this patient actually ended up having HLA-B27 uveitis. And so we're localized treatment. We have anterior uveitis. The patient history is fit and well. Nothing is there. So then we treated the patient with steroids and the patient got better and the HLB27 was positive. So again, so always like think of what's happening. I'll give you another example here. The same optometrist that sent me the first patient who had the iris changes, and I told her that this patient had viral uveitis, sent me a month later, sent me another patient with bilateral chronic anterior uveitis and iris changes. And she was saying, suspecting anterior uveitis, but maybe not showing well on the picture. But this patient actually had cataract surgery, and the iris changes are related to the corneal wound of the cataract. So again, it could be a viral uveitis, but the way it was looking, it was just looking at like it was iris-related changes from the surgery. And that patient just had chronic anterior uveitis after surgery. And there's a name for this, idiopathic post-cataract surgery uveitis. So again, you need to put everything together and just have like a plan. And most important is always think of these big three. So I'll give you an example here where it's very important to have a plan, and touching on what Dina mentioned a few minutes ago. This is a patient coming with retinitis. So I would describe further. So this is actually was a peripheral view, multifocal retinitis. The vessels are involved. There's vitritis. And that patient was immunocompetent patient. So if you put everything together, this is the differential here. Same thing we discussed before: infection, inflammation, and masquerade. So what is the most important to cover for here? Viral retinitis, because anything, even fungal, so fungal, this is unlikely. This is more looking like a retinitis rather than a chorioretinitis. Uh, could be syphilis, it could be toxoplasmosis, very unlikely, it's not in the center. But the most important here to cover for virus. So we have a plan for this. And could this patient be Behçet? Yes, it can be, but even if that patient has Behçet disease, I would rather like not diagnose the Behçet, cover for viral, and we have a plan. Until then, we at some point conclude that this patient has Behçet. And history is very important, because then you want to have the stigma of the Behçet, you have something in the other eye, but still I would be very cautiously diagnosing a patient with Behçet before excluding it's a viral retinitis. So this is the plan. That's what we tend to do. And you always treat the anterior uveitis. You don't wait, even infection, not infection, you treat the anterior uveitis, because that's going to help clear the view later on. And then we get bloods for, most importantly, syphilis. TB as well, we test for. It's very rarely to have a TB retinitis, but we've seen this before. And then we do an AC tap for viral PCR and toxo, and then we start on valacyclovir. Sometimes we give intravitreal foscarnet, many times we don't. I just don't like polypharmacy much, and then wait and see. Usually we get syphilis serology in 1 hour, and we get the viral PCR in about 2 days. At that time, the patient is on valacyclovir high dose, and then it takes from there. So where I practice, and also in England where I practiced before, if the AC tap or vitreous tap comes back for negative for viral, it's not viral. It's very unlikely. There's more than 90% sensitivity and very high specificity. So it's unlikely. The problem is with toxo. It can be negative for toxo in about 35% of patients. But viral, the PCR is really very useful for viral. So that's what we tend to do, and this is our plan for these cases. If you are suspecting viral retinitis in any context, this is what we tend to do. So here, this one, for example, is different. This is a unifocal retinitis in the posterior pole. You can see a branch artery occlusion next to it. You can see the artery involved. That's a primary toxo. This is here. Usually we get the bloods, and this is another case here with a reactivated toxo. And that's another case of toxo. I'll just go to the plan for this one here. So this is usually what we do for these patients. So we get bloods. We don't do AC tap in these patients. In the posterior pole, it's unifocal. The patient is immunocompetent. And when we start Bactrim and oral prednisone at the same time. I'll go back to sorry. Yeah, and you can see here the OCT of the toxo. And again, just be wary. Sometimes if you just only look at the segment of the OCT, you can be confused, because here you can just see subretinal fluid and just some fibrin. But if you look at the area of retinitis, you can see a very significant retinitis, and the choroid is involved some part, but it's mainly a retinochoroiditis. And that's something that we always see in toxoplasma patients. So the question is, so we just said, so it's in the posterior pole, unifocal toxo, right? We don't do an AC tap, peripheral, viral, and we do an AC tap. So what's in mid-peripheral? So mid-peripheral is a bit tricky, and usually we treat them as if they are peripheral. So we do an AC tap and we cover for viral and wait for the toxo treatment. This is an interesting patient who has had virus. So this patient was referred because of possible lymphoma, and the picture is up to the left is the start. And this patient comes in, he's 80-year-old a primary care physician who has rheumatoid arthritis and on methotrexate and steroids, and comes in referred because of possible viral retinitis that is negative twice. They did viral vitreous PCR twice and was negative. And they were worried about lymphoma, so they did also vitrectomy and sent it for lymphoma cytology, but was negative. And then they were saying it's probably unusual viral. But if you can see, the patients has lesions that are healing and patients that are lesions are active. And actually, this patient ended up having a toxoplasma retinitis. So I think the important point is don't believe everything I tell you because we just said that retinitis is always unifocal, but that's not true. In patients who are immunosuppressed or just old, they can present like a viral retinitis. So this actually was a toxoplasma retinitis just presenting as viral retinitis. And that's another case here. It was just old patient who was 80 something and he had like terrible toxoplasma that completely wiped off the retina. And when I saw him, we were not sure if this toxoplasma or lymphoma. And this eye had no PL vision. But the diagnosis was important for implications on the rest of him and the other eye. So we did a chorioretinal biopsy, and that showed actually a toxoplasma cyst, as you can see here in the middle of the section. So I think my point here on this one is always have a plan to, especially these like scenarios, like differential diagnosis of retinitis. You're worried about the virus. How are you going to manage it? Have a plan so that it's easy to teach and also it's easy to follow, and then you don't get lost. On this section, I just want to show you this case here. This is another patient as well who very similarly had these lesions. She's 70 something year female, Caucasian female, and was suspected of having viral retinitis. Intriguing was that her lesion was more in the posterior pole, although she was immunocompetent. And she had, again, vitreous TEP and was negative for viral PCR. And then she was referred to us, and I was thinking either this is toxoplasma or actually this is a lymphoma. And because she's just old. And I did a vitreous biopsy on her, and that came back negative for toxoplasma, but came back positive for lymphoma. And you can see more close here. The lesions are actually more subretinal, and you get the vitreous opacification. And again, it goes with the differential we just discussed. And that's her lesions here. And interestingly, she had a T-cell lymphoma, which is very, very rare. Usually it's a B-cell lymphoma, but this patient had a T-cell lymphoma. So differential diagnosis of retinitis is really very easy. If you're dealing with retinitis, unless it's Behçet, it's most likely an infection or a lymphoma. So it's one of the easiest differential diagnosis in uveitis because most likely you're dealing with an infection. And the most important to cover for is viral. And that's another pattern you see with lymphoma with these RPE changes you can see in lymphoma. Again, on the same token, this is another patient here who comes with decreased vision in one eye, and everything is unremarkable in the history, but you have what you can see here is just anterior uveitis and vitritis, and there's no view of the periphery much, and there's just limited view of the posterior pole. So basically, we're dealing with vitritis, and this is a new vitritis in a patient we don't know about. And again, same thing here. The most concern, especially if you cannot see the periphery, is viral retinitis, and we do exactly the same. So very much the same. So I find this, I was taught this as a fellow with Professor Lightman many years back, and I found this actually approach very, very useful to just cover for viral, have a plan, and then after that we can talk. Toxo can wait, even syphilis can wait. I mean, we're fortunate where I work, we get syphilis serology in an hour. I can stop here, and if you have any questions, I'm happy to continue. I don't know about the time, but I think this might be a very good point for questions if you agree.
ازيك يا دكتور احمد
اهلا
عامل
وسهلا
ايه؟
دكتور محمد، ازي حضرتك؟
الحمد لله تمام. One of your cases, 80 years old with extensive retinitis. I
Yeah.
wouldn't have يعني suspected toxoplasma at all.
Yes.
So how did you come to this
I think yeah.
suspicion?
Yes, I think اول حاجه هو العيان ده كان جاي اتعمل له already viral retinitis وكان negative. تاني حاجه هو I think the point is usually if it's a viral PCR especially from the vitreous and even from the aqueous if it's negative it's unlikely it's viral. تاني حاجه هو we know that we've seen this several times in toxo in immunocompromised patients and even just all patients it can present like viral. The other important differential is lymphoma. So usually, I mean, syphilis is easy to get in the context of retinitis. Syphilis is very easy to diagnose. Usually, it's not a dilemma because of the blood test and the social history. Now we're dealing with viral toxolymphoma. So viral was just a bit very unlikely. So we're dealing with toxo or lymphoma. The vision was no light perception, but then you want to have like know what's happening because of the sake of the other eye. So that's how we reached to that diagnosis. And then we did the chorioretinal biopsy and came back for positive for toxoplasma.
So basically, what you're saying in context of immunocompromised status هو اللي ممكن يحصل كده.
Yes,
So
yes,
just for being an old age is
yes, yeah. Something affects after the age of about 75, 80, something happens to the T helper cells. And you just get some sort of of immune suppression. So and again, we reported this case, but there are other cases reported in the literature. Just in all elderly or immunosuppressed, even just elderly, you can have toxo presenting as viral.
Was there any positive test for toxo, whether like systemic or ocular
Yeah,
fluid,
so the
or
blood test was a bit on the high side. The AC tap was negative,
okay?
and we didn't do a vitreous tap on him on toxo. That was done else, but we did an AC tap and was negative. And again, it takes you back to 35% of patients with AC with toxo PCR, it can be negative, which is usually not the case for viral.
And at this point, like, did you do the biopsy because you thought maybe it's malignancy? Because
Yeah.
if you thought it was toxo, you would just do Bactrim, right?
Yeah, and I think this eye was gone. This eye was gone. It settled nicely after that with
Mhm.
Bactrim, but this eye was no light perception. It's just the implication of the other eye, and the
No,
rest
I
of
mean
him.
like a therapeutic test would make sense too, or you think a biopsy is needed if you didn't do a therapeutic test, or
Therapeutic test to do what? Give him Bactrim.
like, yeah,
I mean, it could be. I mean, it's a
before
no
doing
light.
the biopsy.
Yeah, I mean, I think here it was like an easy one because there's no light perception.
Okay.
And we want to know what's happening. I mean, I think a therapeutic test, I don't know, maybe. Well, I really did not consider a therapeutic test in him. It just was easy one. It
hmm
just this eye is gone.
Yeah, you want to know what's going on, and just yeah, and there's low risk. So.
Yeah.
And
Yeah,
we
to
just
convince the patient best to do the surgery on a non-seeing eye, this is somehow difficult. Yeah.
If you
Yeah,
have
and I think if he
insurance,
refuses, I mean, it's up to the patient, right? You just explain to the patient, and it's up to them.
You have to
no,
explain to the insurance
patients,
too.
insurance, but patients want to know what they have because they're anxious and they're worried, like, well, whether maybe it's cancer, so.
Yeah, and I mean, yeah, it just I think يعني حل اللي انا وجدته مع القصة دي انا I'm the advocate, I'm the health advocate. I'm not the one taking decision. My role is to explain to patients and give them the information to make decision. As long as they are competent يعني brain competent they take their decision. انا بس عليا ان انا افهمهم. And that's another patient again on the same. This is actually was patients who was on methotrexate and
Netflix.
steroids, and that
Yeah.
actually was a toxoretinitis as well.
Dr. Ahmed, I sent a case in the chat. Can you tell me what do you think about this color photo? Like, what would you do in this case? It's a female patient. She's 40 something years old, no medical history, and panuveitis, and this lesion is in the back. What will your thoughts be?
And شايف صورة OCT بس هادي.
ده color photo فوقيها، هل حضرتك شايفها؟
Yeah, so the patient has what just as how old is the patient? And this a retinitis
She
or
she she's 40 something, and she presented with unilateral panuveitis, and I think she didn't have a view in the beginning, so we started her on topical anti like steroids, and then like when the anterior uveitis cleared up, we started to see this lesion in the back. So like that's basically the history. She doesn't have a medical history or anything, and the
and do you
labs
have an
basically came.
OCT on the lesion or
Yeah, it's the same OCT down there. And basically, all the labs were negative, and PCR. When I saw this lesion, I did a PCR testing, and it was negative.
so PCR from the aqueous
Yeah.
and was negative, and the patient is immunocompetent?
Yep. No, no medical history. She's healthy.
Okay, and how long has it been going on?
I mean, when she presented to me, I would say like a month, and then
Yeah, so it's unlikely that this is viral. Viral would have wiped off the retina, and also the patient is unifocal. I would treat it as toxoplasma. Is the blood's
yeah.
high for toxoplasma antibodies or no?
No, everything was negative. So basically, like we treated her for a long time, and all the inflammation went away. And then this lesion persisted, and eventually, I just honestly diagnosed it as myelinated nerve fiber. I'll send the follow-up. Like everything went away, and the lesion just persisted for like, and it kind of looks like atypical for myelinated nerve fiber because it's like, I mean, irregular a bit, but that's basically the lesion just persisted, and that was the OCT. Do you think
But the
like,
patient had uveitis, had vitritis.
yeah, she has panuveitis. She had like everything, like the AC cell, vitreous cell, and that all cleared, and her vision is 20/20 now, and the lesion
Right.
is just still there, the same. And and the OCT is there, just showing like the inner retinal hyperreflectivity. So I just basically diagnosed her as myelinated nerve fiber.
Oh, you have pictures, Hina. Yeah, that's interesting. I mean, don't know. It could be.
It's a very weird masquerade, right? But I just wanted to bring it up too, because like it's a pretty rare situation, but I mean it happened to me, so.
So
Yeah, but
I'm
it's very brave to give the patient with panuveitis and not seeing at the back steroids from the word go. That's very brave. So it's a very interesting case.
Yeah,
so
we give her like topical steroids, and like you said, like for the anterior uveitis, and then did the lab work, and then when she came back in a week, I started to see that lesion, and then like the labs were negative. I did PCR because when I saw that lesion, I did
So the patient
PCR
had
detected.
panuveitis or had anterior uveitis?
No, she had pan, but with anterior, like I mean, with I couldn't see the back because she had like
that's
anterior like cells, yeah, like AC cells, and I don't
Right.
remember like, and it was pretty hazy in the vitreous, so she had a panuveitis, but I mean like she didn't have a view in the retina. And then when I started on the topical steroids, waiting for the labs to come back and clearing up the view, I started to see that lesion. And then I started to think, okay, maybe it's probably a retinitis, and I thought like viral, etc. And then all the testing came back negative, and then everything cleared up, and the lesion stayed there. And then basically for me, the diagnosis was probably myelinated nerve fiber.
it's interesting ان الاو سي تي ما فيهوش سيلز على الليجن او جنب الليجن او كده برضو. it's one of the interesting things in الاو سي تي.
I agree, yeah, because like it would have been more cells there, right? Yeah, it's
yeah.
very clean. It's very clean. Mhm.
يعني I wouldn't say a similar lesion, بس I had an interesting patient recently بس كان عنده posterior subcapsular cataract, so eventually we went in and removed the cataract, وكانت الكاتراكت blocking ال view of the periphery، بس كان في lesion hazy كده في البريفري، وعملنا البي سي ار عشان شلنا كده كده، دخلنا شلنا
Mhm.
وطلع human اسمه HHV1 human herpes v sorry human herpes virus 6 HHV6. ما اعرفش
Oh,
ليه.
okay. Yeah, I think this is one of the things that cause like rashes in pediatric patients or حاجة
I
كده
know
like.
he's a new immune
Yeah,
competent 25 year
yeah.
old big guy refused treatment، بص لي على اني يعني ايه، مش شلنا الكاتاراكت وبقيت كويس. باي باي. ودي الحاجات اللي I think ان كل الناس بتفكر فيها، وانا بس هقولها عشان دكتور ايمن دكتور سلام they practice outside of Egypt. وعشان كده ايمن قال على فكرة الثيرابيوتيك تشالنج، ان احنا بنلاقي صعوبة ان احنا نقول للعيان احنا محتاجين نعرف في ايه في العين. ده رأيي، معرفش الناس اللي بتبراكتس في مصر هتوافقني ولا لأ. بنلاقي صعوبة في ان احنا نقنع العيان ان احنا محتاجين ناخد اي حاجة invasive. ف enhance موضوع الثيرابيوتيك attempt.
like for Bactrim specifically يعني or
uh, trust me for almost anything and everything. دكتورة يمنى غريب عايزة تقول حاجة بس أنا مش بعرف. help يا مي help.
انا ما سمعتش المسج اللي هي عملت ايه.
دكتورة يمنى غريب رفعت ايديها.
آه، طيب نخش على البارتيسيبنت. انا ما خدتش بالي، معلش انا اسفة.
عليهم.
Do you want me,
طب
shall I continue with the
yes
rest of the five one
please.
or is it too much?
طب
I don't want
دكتور
to like
يمنى you
give you
can
too
send us
much.
message. send us message. دكتور احمد بس بيكمل we will send us message we will come back to you يعني. انا اسفين ما
Sure.
خدتش بالي من هذا. اتفضل يا دكتور احمد.
Sure, no, no, أنا معاك وأنا بس مش عايز يبقى الموضوع is too much please if you feel it's too
لو
much
احنا
let me know.
مأخرين حضرتك قول لنا، بس
لا لا
احنا
خالص بالعكس، هو
مستمتعين
الوقت
جدا.
عندي هايل.
لا احنا
أنا I'll
مستمتعين
try
جدا.
to يعني بالعكس. Okay أنا بس عايز أشوف wait well I think the continue to share. I'll just give you again another case. I think something very important is to always like try to think why is the vision decreased. I think it's important to be pragmatic when you're dealing with uveitis and don't get distracted into details. So have a plan. Don't get distracted into so this you want to be like يعني you want to collect information, but you want to have also like a pragmatic approach. Okay, are we dealing with masquerade, infection? If not, we're dealing inflammation. Okay, fine. If we can reach that is sarcoidosis, well and good. If not, then fine. Undifferentiated uveitis is good. The other thing is, why is the vision down? This is something very important. And again, I just want to mention one point. Usually the vision is down because of cataract or CME. So remember, all these things start with a C. KPs is very unlikely unless it's all dusted. Bankeratopathy in kids is an important cause, but it's usually cataract CME. Vitritis itself can cause decreased vision. Usually it needs to be a lot of vitritis. I mean, there are other things, epiretinal membrane. You can have also like a choroidal neovascular membrane, as in this case. The most important cause of decreased vision in uveitis, even anti-uveitis, is cystoid macular edema. So something to be wary of. So always ask yourself, why is the vision decreased in this patient? To tie up with this is, when do we treat patients? We treat patients when it's vision involving or we know that this disease is vision threatening. I think a very important topic here is patients with intermediate uveitis. I've seen patients with intermediate uveitis being always treated, which is, I don't think is needed. You treat patients with intermediate uveitis if it's vision involving or vision threatening. So if those patients with some mild vitritis or snowballs or snow banking, unless it's really causing cystoid macular edema or it's significant vitritis to affect the vision, or you have significant lesions in the periphery like retinoschisis or vasoproliferative tumor tells you that this is a bad disease, then I would not treat patients with intermediate uveitis. Usually you watch them and they tend to do very well and they grow out of the disease. It's one of the diseases when you get older, you get better. But always think, why are we treating the patient? Why is there something decreasing the vision? And do we need to treat this patient or not? Because some disease they don't need to be treated. Some uveitis, they do not need to be treated. So the thing is, vision involving or vision threatening. The other one, which is important, steroid, is this like a friend or a foe? Is it a bad thing or a good thing? And I think steroids are fantastic, systemic steroids. They are the best thing to use to test the water. So I would not treat anyone with new uveitis with intravitreal steroids. So if I'm reaching like, okay, this is unlikely masquerade, it's unlikely infection, or if we excluded infection with tests, or we think this is unlikely for whatever reason, then the next step is I would test the water always with systemic steroids. Very easy to stop, controllable. And then after that, even if it's unilateral disease, then I will decide, okay, well, it's a unilateral uveitis. The patient is already pseudophakic. Let's treat this patient with intravitreal steroids. And I think that's absolutely fine. But I would not treat a new patient with intravitreal steroids where I'm not really sure, even if it does not look like infection. But it's a fantastic medication or fantastic utility to test the water. But then on the other side, I would use with caution, and we've seen a lot of patients with significant side effects from steroids. So I think once after you test the water, then your aim is, okay, this patient needs treatment, then we'll have to keep the steroids at a very low dose. In the books, it says 10 milligram, now changed to 7.5 milligram per day. I think it has to be less than 5 milligram or less, so as not to get cushingoid and side effects. You still have to cover for bone protection, which is very important. But we try to keep the dose at a minimal and use other medicines, especially in kids. I mean, systemic steroids in kids is just only for testing the water because they can get lots and lots of problems. Bone affects their growth, lots of issues in kids. So just be wary. Don't keep patients on high dose steroids for a long time. You're actually you're doing them harm than good by keeping them on high dose steroids. But it's a fantastic medicine for testing the water. As for treatment for uveitis, I think, again, if you tell me that this patient has toxo, open the book, toxo chapter, very easy to treat, right? If we reach out that this patient has a non-infectious uveitis affecting the posterior segment, again, I think it's easy to treat. It's just the problem is what does this patient have? And the first thing is rule out infection masquerade. And then after that, you start thinking, does this patient have unilateral, bilateral? Is systemic disease? Is it part? What comorbidity is this patient? How serious is this patient uveitis? For example, periocular steroids, they're really like not that aggressive treatment. So it may work for a very mild intermediate uveitis with macular edema, but it's not going to work when like there's too much going on. That you need to go more serious than this. And again, remember, always test the water with systemic steroids if in non-infectious uveitis. I'll just give you an example to put things in the context. So this is like a 54-year-old female patient. She has panuveitis with vitritis and cystoid macular edema. Again, episodes of recurrence over 6 months after stopping systemic steroids. So you know that, okay, well, this patient responds to treatment well, but you stop the treatment, it flares up. So what does this patient need? This is the analogy now of hypertension, needs a long-term treatment, right? And now the patient is even on 30 milligram prednisone, but when you taper down further, it just flares up. So now this is where the name of the medicine's steroid sparing medicine. So here, that's what we tend to do. Usually there are lots of medicine, but usually our first go medicine is CellCept, mycophenolate mofetil. It's very nice. It's very easy to monitor. It works so well for the eye, better than methotrexate and azathioprine. So that's what I would do. I will keep the steroids on 30 milligram if she's not flaring up on 30, or even put it up high. Introduce mycophenolate mofetil and keep that for about a month, and then after that, try to start tapering down the steroids. And my aim is to get to 5 milligram or less, and to keep the CellCept for at least 18 months. And we start counting from the time the patient is inactive, not from when you started the CellCept. And in many patients, you stop the immunosuppression, it comes back again. So what we tend to do nowadays is we keep the patient on immunosuppression really for long time, even for life, unless we're getting problems with it. And especially kids, more than 60% chance of flaring up when you stop immunosuppression in kids. And I think it's sensible to try, but you just need to have realistic expectation that at least 50% of patients will flare up again in about 6 to 9 months after stopping immunosuppression. But the main point is, I think CellCept is a great medicine, and I really like it, and I know it's available in Egypt now and it's cheap. And then usually, if it doesn't work, the second medicine is usually go anti-TNF now. I mean, we had success before using 2 anti-metabolites, CellCept and methotrexate. We try to avoid cyclosporin because all patients is not good for the kidney. In kids, it gives side effects that are not acceptable in kids. So usually it's CellCept, then the next one is anti-TNF, Humira. But the important point is to keep the prednisone low. So I have questions for you, uh, whomever would like to help. So what do you think about systemic treatment versus intravitreal treatment in terms of efficacy? And that's a reflection on the MOS trial. And then my second question is steroid versus immunosuppression. Does immunosuppression really improve the vision as compared to steroids? And then my last question is uveitic CME, what's the most potent treatment? And I'm happy to answer them or we can go into discussion with them. Maybe I think I can finish my last point and then we can go into discussion of these points again. I think this is very important. And if you get anything out of this presentation, I would say two things. One is the differentiation between recurrent anterior uveitis and chronic anterior uveitis, because that will save you a lot of time dealing with these patients who think that they have recurrent anterior uveitis and you're just stopping their drops. And the second is this one, how to smell infection. And history is very, very important in uveitis. So history of comorbidities, like Dina was mentioning, patients who got admitted or had GI surgery, that tells you this is a story of endogenous endophthalmitis fungal. Social history of, pets or high risk sexual behavior or traveling or hiking, that gives you suspicious of syphilis, for example, or intravenous drug use or Lyme disease. Retinitis is almost always infection unless you're dealing with Behçet or a lymphoma. It's a very easy differential. MP and serpiginous, yes, they are usually non-infectious, but you have to, in these patients, we know that this pattern tests for TB and syphilis. Get this out of the way. Then after that, if you're dealing with MP, then whether you're going to treat them or not, it's up to you. Serpiginous, they need treatment. There's one of, sorry, I've missed a slide here I was meant to show you. So we go with the pattern we discussed before, that you use steroids for treatment of panuveitis, then you taper down, and then if they flare up, you introduce second-line immunosuppressive. But there are diseases where you know from the word go, they need immunosuppression from the beginning because they do very bad, like serpiginous, birdshot, VKH for at least 2 years, and necrotizing scleritis, ocular cicatricial pemphigoid. From the word go, once you've made these diagnoses, then you need to reintroduce a second line immunosuppressive medicine from the beginning, because steroid is not gonna change the pattern of the nature of the outcome of the disease. Okay, let me go back to where we were. Yeah, and again, worsening or no improvement on steroids. That's why it's nice to test the water on systemic steroid. I wouldn't test the water with intravitreal steroid, and then you find like, that was a retinitis, a viral retinitis just suddenly like blown up. It's a terrible situation. So I would not do that. And pattern recognition, like for example, this pattern, that's a very suggestive pattern of syphilis, right? And this budding lesion, we don't have this in medicine or in ophthalmology except two things, right? Choroidal melanomas, budding masses, or fungal. So you don't get this pattern much. For example, this is not toxo. You don't get this like volcano appearance in toxo. This is like fungal. So if you're thinking this is a toxo versus fungal, that's fungal. And you can see that here on the ultrasound scan. You can see the lesion there on the ultrasound scan connected with the vitritis. This like budding lesion, that's fungal. And then my last slide is in uveitis. I think it's very important always to be humble in uveitis and have the door open for diagnosis, revising your diagnosis. Always know how to test the water. Have a plan of management, like what we discussed about the management of like new patients with vitritis or new patients of retinitis. Even if you end up like putting more patients on valacyclovir, but I think this is fine. It's an outpatient treatment now. It's very easy. It's very available, and most patients are fit and well, so the kidney can manage that for a few days until you have an answer. I would rather do that than start patient on systemic steroids and then finding that I've missed the patient with viral retinitis and the whole retina now is on fire. And be suspicious. Like I'll show you a case here, which is interesting. This is a patient was referred for epiretinal membrane and peeling, and the patient, if you speak to them, their symptom is very weird. Like my vision is a bit down, but I also have floaters. And then when you look at the retina is not right. It's not an epiretinal membrane. You see the outer retina is involved, the contour of the retina. And you think, okay, well, actually, it's an epiretinal membrane. It's probably secondary to something, affecting the outer retina here. And that's their OCT. I mean, there's areas of thinning as well as the thickening in the retina. And that's their fluorescein. Again, weird, like some sort of leakage there, but nothing too much. And that's where ICG is very important. It gives you a very good view of the choroid. And that actually patient ended up having a bird shot. The patient had a bird shot, and that was a secondary membrane. Just that's all what you're seeing. Again, it's the tip of the iceberg, but this is not the problem. The patient problem was, and decreased vision, which is like just unexplained, was due to choroidal disease from the bird shot. That's another one here. This is actually a case I missed, and the fellow diagnosed this. This is a patient who had decreased vision, and on the OCT, you can see here just these areas of opacification in the inner retina and very mild change in the outer retina. I thought this patient really had a ischemic event and a branch artery occlusion. But the fellow quite right really put together that there are stuff in the vitreous that I missed. And you're right, if you put things together, vitreous cells and something happening in the retina, okay, it's more inner retina, but there is something happening in the retina and the features are distorted there and a bit in the outer retina. Actually, this patient had PERT, had punctate inner retinitis. And we did the serology was sky high, the blood serology for toxoplasma. So I think, again, always be open to the diagnosis and think, am I missing something? Especially that the overlap between ischemic disease and how retinite or how and uveitis is actually, there's an overlap. Like, patients with, for example, vein occlusion, when it's very severe, they may have cells in the antechamber. And ocular ischemic syndrome, we've all seen them with flare and maybe a touch of cells in the antechamber. So there's a bit of overlap. So always be suspicious of this. I think this is all what I had. I'll just come to the questions that if you want to discuss them between ourselves, which is again, systemic treatment versus intravitreal treatment for non-infectious uveitis and steroid versus immunosuppression in terms of improvement of the vision and uveitic CME. And thank you so much.
شكرا جدا يا دكتور أحمد. Very nice presentation الحقيقة.
Thank you.
Thank you. مش عارف حد عاوز يسأل؟ أكيد في a lot of questions.
أنا عندي أسئلة كتير، بس أنا I'm afraid that time might be running. إحنا محتاجين بس هند تعرض.
ممكن نقول نخلي هند تقول وبعدين نعمل الدسكشن عشان لو حد يعني احنا اتأخرنا عليه في الوقت. بس انا عايزه اجاوب على اسئله دكتور احمد، بس نخلي هند تقول الاول وانا عندي اجابه. اتمنى تكون اجابتي صح. هند ار يو رازل؟
يا أنا معاك اوريدي.
طب شير سكرين كده. بس دكتور احمد بجد ما حدش ليه حجه بعد كده لو ما بقاش يوفيتس بجد.
Just the name.
البرزنتيشن هايله، تسلم ايدك.
It's a catchy title.
Okay, can you see my screen now?
Yes, please.
Yes.
Go on.
اوكي، مساء الخير. اولا شكرا جزيلا دكتور مي على الانفيتيشن، وشكرا دكتور محمد، دكتور علاء، ودكتور سمير على يعني المجهود في ترتيب الويبينارز دي، وطبعا دكتور احمد ودكتور دينا. يعني it's very hard to take the stage after them. ف thank you very much for the very nice presentation. أنا هتكلم النهاردة على الإندوجينوس endophthalmitis. الحقيقة هي من التوبكس كده اللي هي بحس إنها مهضوم حقها شوية، يعني هي اللي هي شبه الحالات اللي بنشوفها كتير قوي في اليوفيتس، زي يعني I mean باليوفيتس inflammatory or autoimmune diseases، ولا هي زي post surgical endophthalmitis اللي هي كل الكونسلتنت سيرجن بيتكلموا عليها كتير. فبحس إنها كده إيه يعني مهضوم حقها في النص. حبيت إن أنا هايلايت حالات الإندوجينوس endophthalmitis. النقطة التانية والمهمة إن أحيانا الحالات دي بتبقى misdiagnosed initially as a uveitis، و I mean by uveitis إنها non-infectious uveitis، و we receive course of systemic systemic steroids or immunosuppressive treatment which actually make things worse. أنا يعني حبيت البرزنتيشن النهاردة هتبقى في صورة cases. الكيسز دي هيبقى منها straightforward cases with very clear history و typical presentation، وحالات تانية which is like atypical presentation كانت الحقيقة challenging جدا في الdiagnosis بتاعها. So let's go for the first case. A 68-year-old patient presented with 1 week history of right eye drop of vision. The past ocular history was like just cataract surgery in both eyes 5 years ago. The past medical history which is the most important part وده اللي لازم نفوكس عليه قوي في حالات الانdogenous endophthalmitis. العيان كان diabetic. We 2 weeks earlier before the presentation كان hospitalized for poorly controlled diabetes with mild ketoacidosis. On presentation, the vision can hand motion for right eye. There was a hypopyon in the AC with anterior vitreous cells, dense anterior vitreous cells. وده كانت posterior segment examination. طبعا this is the classical case of candida endophthalmitis. يعني دكتور أحمد لسه عارض حالا. فدي white fluffy lesion with cotton poles with exited dense vitritis. This is candida endophthalmitis without even any investigation. Very evident. في حالات الاندوجينوس endophthalmitis اهم حاجه هو السيستميك ورك اب. انا الاندوجينوس endophthalmitis في اقاويل اخرى اللي هي الميتاستاتيك endophthalmitis هي actually عباره عن في source of infection في البادي بيبدا ان هو يبعت شاورز في بقيه الجسم. العين جزء بيوصل له جزء من الانفكشن ديت، وبتوصل للكرويد which is highly vascular structure، وتبدأ الأورجانيزم يجرو in the choroid and then breach the blood retinal barrier, invade the retina and then the vitreous. فأهم حاجة المين aim إن إحنا to detect the primary source of infection. الحالات دي ideally إن إحنا بنعمل routine workup of uveitis, exclude all causes. بس the most important thing to ask for blood culture and urine culture, just try to find out what is the primary source of infection. And sometimes if the patient has chest-like manifestation, then we can ask also for sputum analysis. مهم قوي ان احنا نبدأ systemic treatment من غير ما نستنى even ال results بتاعت اللابس. ففي الحالات دي يعني I prefer ان انا ادي oral voriconazole اكتر من الامفوتيرسين بي، ده لان الفوريكونازولز ليها better ocular penetration than amphotericin. The induction dose is 6 mg kg twice per day for the first day, and then oral 3 mg per kg twice per day for 4 to 6 weeks. Whether to give the induction dose intravenous or oral يعني ما فيش فرق قوي، بس يعني I prefer ان انا ابدا بالintravenous الاول for at least the first day. وطبعا very important to monitor renal profile. الحالات دي طبعا endophthalmitis, then we have to get tab and also inject intravitreal antifungal, especially إن العيان عنده dense vitritis. 2 days post injection we starting systemic treatment كان ال EC reaction improve, but still we have dense vitritis. That's why we considered vitrectomy in this patient with vitreous biopsy and intravitreal injection of voriconazole again. ويعني I prefer في الحالات دي ان احنا لو هندخل نعمل vitrectomy and get vitreous biopsy, it's better to get concentrated vitreous biopsy under air first and then we can proceed with the vitrectomy. 1 week after surgery the vision improved 0.8, EC كانت quiet, sear segment طبعا cleared, and then like we can see here few choroidal lesion persist, but it will be covered by the systemic antifungal anyway. The results showed that positive candida in the urine culture, however, the vitreous sample was negative. So again, the pathogenesis of endophthalmitis, as we mentioned, is like the metastatic endophthalmitis. Then we have to search for the primary source of infection. الحقيقة في many risk factors. The most important is diabetes, like because it's immunocompromised status by itself. وalso لأن الدايابيتس فيه microangiopathy فال blood retinal barrier already بيبقى weaker فبيدي chance للinfection to invade the retinal tissue more. However المهم قوي اللي أنا حابة أفوكس عليه إن أحيانا there is no identifiable risk factor وده does not exclude إنها ممكن تبقى endogenous endophthalmitis. في الكندا endophthalmitis البوزيتيف blood culture is positive for 50 to 75% of cases فبالتالي negative culture doesn't exclude the infection. And also the vitreous biopsy, which we get the vitreous biopsy by the vitrectomy, like better than the vitreous sample by the needle biopsy. However, it's up to 90% of cases came out positive, so we still have chance of negative culture, and this does not exclude also the infection. في برضو يعني بيسجست ان احنا ممكن نستخدم طبعا البي سي ار if available او affordable للعيان وفي باي ماركرز زي الجلاكتومانان والبيتا دي جلوكام like cell wall component of invasive fungi, so it could give like indicator ان الحالة دي فيها fungal infection. Again, as I mentioned, the ocular penetration of the voriconazole is better than the amphotericin. طبعا انا مش هتكلم عن الاو سي تي. دكتور دينا covered الاو سي تي ساينز لحالات الفانجل اندوثرمايتس ودكتور احمد طبعا. طيب بالنسبه للتريتمنت اوبشن احنا عندنا في حالات الفانجل اندوثرمايتس it depends on the presentation. فلو العيان جاء early with peripheral choroidititis lesion like this case, then it's more than enough to give the patient systemic antifungal, and that's enough. بس لو العيان presented with macular threatening choroidititis lesion or multiple lesions, then it's better to add intravitreal injection of anti-VEGF along with the systemic antifungal. يعني as a chance ان احنا نزود ال concentration of the drug inside the vitreous cavity. In this patient, العيان can presented with choroidititis with dense vitritis. That's why we need to give intravitreal injection of anti-fungal as well as the vitrectomy. The second patient is a 59-year-old patient presented with 1 week history of bilateral drop of vision. Right eye is much more affected than the left eye. Again, the past medical history is very important. The patient is diabetic, had testicular abscess, UTI, and an urine catheter. And he was initially misdiagnosed and he received a course of systemic steroids before presentation with no improvement. So the vision in the right eye was hand motion, left eye was 0.6, and there was like dense reaction in the right eye, less than, with the left eye less inflamed. This was a posterior segment. Again, the right eye, you can see there is dense vitritis, many colonization, and many vitreous condensation and infiltrates. And here in the left eye, we can see this focal choroidititis lesion. This is OCT over the choroidititis lesion, showing the retinal and the vitreal involvement with shadowing of underlying tissue. So again, the systemic workup is the most important thing. The patient already presented with UTI and he has a urine culture with showed positive Klebsiella. Like it was the culture and sensitivity was very bad. It was resistant to all antibiotic except cholestyne, which actually has very poor ocular penetration with undetectable in concentration vitreous sample. So we give the patient a bilateral intravitreal injection of antibiotic. Preferably we give ceftazidime and vancomycin. And we opted for the right eye because of the dense vitreous inflammation for right eye vitrectomy. This was the outcome after surgery. The right eye, the vision improved to 0.3. There is no vitritis, but we can see there is central choroidititis lesions. Vitrectomy will not help with this lesion, so we keep injecting the patient intravitreal injection of antibiotic and continue the systemic antibiotic. However, the left eye, with time, get more vitreous inflammation. Then we opted also for vitrectomy for the left eye. In bacterial endogenous endophthalmitis, the most common organism usually in Western countries is the gram-positive bacteria, staph, and the streptococci. لكن في Asian countries, the gram-negative like Klebsiella and E. coli are more common. المين تشالنج الحقيقه في حالات البكتيريال endogenous endophthalmitis هو systemic antibiotic, which is generally less ocular penetration than the antifungal. الفلوروكينول fourth generation fluoroquinolone زي الموxifloxacin and levofloxacin has the best penetration, however it's lower than the antifungal anyway. Then the second generation fluoroquinolone like ceprofloxacin, and then the aminoglycoside amikacin with very low penetration, and ceftadizine is the lowest one. So in such cases with bacterial endogenous endophthalmitis, unlike الحالات الفانجل endophthalmitis ان احنا قلنا لو هي بس retinitis lesion ممكن نكتفي بالسيستميك تريتمنت. الocular penetration دي الانتيبيوتيك is very low, that's why we usually give adjuvant intravitreal injection of antibiotic in such cases. The third case ودي الحقيقة كانت من الحالات الchallenging جدا، وأحب قوي لو يعني my consultant and professors attending the webinar النهارده يعني يقولوا آرائهم برضه في الحالة دي. It's a 16-year-old patient presented with left eye drop of vision for 1 week. In post-ocular history, nothing, no trauma, nothing at all. In medical history, nothing at all, absolutely fine, and nothing systemically. And on presentation, on examination, the vision was hand motion in the left eye with hypopyon and dense inflammation, and this was the fundus photo. So you can see here there is what we call posterior hypopyon, and also there is white fluffy lesion with dense vitritis. So this was a very complex case actually. وكنا يعني فكرنا كتير ايه ممكن الcauses، يعني we excluded everything, we did extensive systemic workup for this patient and everything turned out negative. بس الحقيقة يعني like after getting many consultation from many consultants, the decision was to better safe than sorry, give the patient, get the vitreous biopsy, get the patient intravitreal injection of antibiotic, and let's see what will happen. And surprisingly, 1 week after injection, it's improved vitritis. There is no hypopyon now. Even the anterior chamber reaction improved dramatically. No steroid at all. And unfortunately, the vitreous sample was negative, but we started the patient on systemic antibiotic. The last case is also a bit confusing case. It's 34-year-old lady presented with bilateral drop of vision in both eyes for 3 days. The post-ocular history was unremarkable. The medical history, nothing except she's breastfeeding, and she had flu 3 weeks prior to the attack, nothing else. And before that, the patient was absolutely fine. So the vision was counting finger in both eyes. There was severe inflammation in both eyes, hypopyon, and this was the posterior segment. There is dense vitritis in both sides, and also there is inferior-like colonization here. The vitritis is much more dense in the left eye than the right eye. So again, the intensive workup was negative for everything, and we decided to go for injection. We suspected fungal endogenous endophthalmitis, so we went for bilateral injection of antifungal in both eyes with vitreous biopsy, and we stored systemic antifungal as well. So 1 month post-injection in the right eye, so we can see the vision improved to 0.5, marked improvement vitritis, everything looks fine in the right eye. The left eye improved, but still there is dense vitritis here, so we opted for vitrectomy in the left eye. So my take-home message in such cases of endogenous endophthalmitis, negative culture, whether blood, urine, vitreous, does not exclude endogenous endophthalmitis, and the lack of history of risk factor, again, does not exclude endogenous endophthalmitis, and the younger age group also does not exclude endogenous endophthalmitis. So always suspect endogenous endophthalmitis. Keep it in your mind. The immediate systemic evaluation is very important. However, do not delay treatment while awaiting collapse. So start the pro-spectrum antimicrobial agent, whatever you suspect fungal, give the pro-spectrum antifungal, suspect bacterial, give the pro-spectrum bacterial, also with adjuvant intravitreal injection if needed. The systemic antibiotic alone in bacterial endogenous endophthalmitis is not sufficient in most cases because of poor ocular penetration, so combine it with intravitreal injection. The dense vitritis, diagnostic uncertainty, and the poor response to intravitreal injection are strong indicators for early vitrectomy, so prepare yourself for vitrectomy for such patients. Thank you.
شكرا يا دكتورة هند جدا على البرزنتيشن الجميلة. السؤال ليكي when do we when is it enough ان احنا ندي systemic antibiotics او ان احنا نديسايد ان احنا ندي intravitreal. امتى بنعمل الديستنكشن ده؟ هل do we start first ندي مثلا levoflox and see what happens، ولا should we from the مثلا لو في budding of secondaries جوه الفيتريس should we decide ان ده عمره ما هيوصل السيستميك هيوصل للفيتريس and we do vitrectomy at that point، ولا رأيك ايه؟
هو as I mentioned في السلايد هنا، دكتور محمد اهو هنا، ان احنا يعني غالبا لو انا بتكلم في chorioretinitis بس ف systemic treatment is enough. بس هي المشكله في حالات البكتيريال ان ال ocular penetration is poor with most of the systemic antibiotics. That's why it's advisable to give intravitreal injection as well. لو هي like macular threatening, many lesions in the fundus, then and also budding like that, so it's better to give intravitreal injection as well, لان انا عايزه ازود ال concentration of the drug inside the eye. بس لو في dense vitritis from the start، يعني احنا كده وكده بنتكلم ان احنا هنعمل vitrectomy sooner or later، سواء vitrectomy في ال early stage لو هو not responding للتريتمنت، او later on لان في شويه vitreous membrane اتبقت بعد حتى even after resolution of infection, so we need to clear up the media. That's why we need to go for vitrectomy.
اوكي، انا بسألك لان في كذا حالة يعني actually مثلا تلتين الحالات I just gave them systemic antibiotics and they resolved.
The systemic antibiotic يعني الحقيقة هو ممكن يعني ده يحصل فعلا، بس it depends حسب ايه نوع الانتيبيوتيك. يعني العيان اللي انا كان presented مثلا في الحالة هنا
Why
في
did this patient got worse and the others didn't يعني؟
maybe the organism, maybe the burden of the organism, maybe the type of antibiotic used. Like levofloxacin has good penetration, but sometimes the culture given like antibiotic sensitivity give antibiotic which with poor ocular penetration. like زي الحالة اللي أنا عرضتها مثلا، هو very poor ocular penetration. That's why he will not benefit from these systemic antibiotics. So we need adjuvant intravitreal injection.
يعني بعتمد يعني على بعتمد اكتر ان زي مثلا عيان عنده abscess somewhere in the body and عملنا culture to this يعني sample اللي جايه من مثلا من الابسس دي and we found an organism that was sensitive to a certain antibiotic. So I assume ان اللي جاله الميتاستاتيك يعني endophthalmitis انها secondary to this organism, and based on this اديت له الانتيبيوتيك that يعني الكالتشر طلع sensitive against. ف
Yes.
ف it's not دايما انه بيحصل improvement probably because the organism has entered the vitreous, and the reach of systemic antibiotics is good for the choroid, but once it has يعني established colonies inside the vitreous, it's probably more difficult to reach with systemic antibiotics alone and requires intravitreal at that point.
Yeah, I guess, yeah, exactly.
Exactly. I think that's our experience as well. So if they are flat chorioretinal lesions, then systemic is alone. Once they get raised, then they are actually like breaching now the blood, the outer blood aqueous barrier, and it's not going to reach well. So that's where antibiotics are needed. So if we are like talking endophthalmitis as the word defines, then they need additional intravitreal antibiotics. If we're talking just chorioretinitis, especially it's a flat chorioretinitis, then systemic treatment is enough.
Thank you very much. في حد عاوز يسأل على حاجة تاني؟
دكتور أحمد، كان عندي بس سؤال أو كومنت صغير كده. حضرتك قلت في كيسز التوكسوبلازما في البلان اوف مانجمنت حضرتك بتدي simultaneous الانتيبيوتيك with systemic steroids.
Yes.
I know this is يعني well known وفي الليترشر موجود كتير، بس حضرتك مش يعني أحب بس الناس نسترس إن احنا نقول لهم إن هم يبتدوا الاتنين سوا ساعات مثلا العيان يروح، بما اننا هنا بنشتري من الفارماسي عادي، فممكن يلاقي مثلا الانتيبيوتيك مش اللي انت كاتبه مش موجود او غالي شويه، فالدماغ تقول له طب بص اشتري بقيه الادويه ابتديها دلوقتي اتحسن بيها شويه على ما الباقيين، فنسترس بس على البيشنت ان احنا نبتدي الاثنين دول مع بعض. يبقى ما نبتديهمش غير لما نلاقي الانتيبيوتيك، عشان بس التعديلات اللي بتبقى احنا مش متوقعينها تحصل من العيانين.
لا لا ايفن
بالنسبه
في حاجات النقطة التانية برضو المهمة تأكيدا لكلام حضرتك ان هو آه، ساعات العيانين بيوقفوا الانتي بايوتكس وبيكملوا بالستيرويدز، فهو وي emphasize this ان هو الاثنين لازم يمشوا مع بعض، وان هو at no point تاخد ستيرويدز من غير انتي بايوتكس، لحد ما توقف الستيرويدز it should be covered all the time for antibiotics. So antibiotics is not like a week or 2 or 3 weeks. It's as long as the patient is on systemic steroids, they need to be covered all the time with antibiotics.
اكزاكتلي. وده برضو الكونسلنج بتاع العام الاول، احنا بنحط بلان، احنا هو فاهم ان احنا مش هناخد زي دور البرد انتي بايوتيك اسبوع ولا 10 ايام ونوقف فالانتي بايوتيك بقى نتعب، لا احنا متفقين من الاول على رحله علاج وعشره طويله مع بعض. فدي بتفرق كمان مع الكومبلاينس بتاع العيان. بالنسبه لاسئله حضرتك لو انا فاكراها صح، سيستميك ولا انترافيترال؟
Yeah, هو كان again systemic versus intravitreal steroids. Which one is more potent? Which one is better for the vision for non-infectious uveitis? I think that was one of the discussion points.
اعتقد انا بيبقى المحرك الاساسي بالنسبه لي طبعا، وانا مش في اساتذه يعني اشطر مني كتير موجودين، هو يونيلاترال ولا بايلاترال، هو ده بارت اوف سيستميك ديسيز ولا ايديوباثيك. وخليني اقول ان احنا في القصر العيني يمكن دي مش published داتا، بس كمان السبتينن لقيناه، يعني لو انا هدي مش هحط بقى implants زي اوزرداكس او whatever، بس just one injection، كان بيساعدنا كتير في الحالات، واسهل كتير في ان احنا نعمله من الانترافيترال ستيرويدز في الحالات اليونيلاترال. فهي دي الحاجات اللي بتخليني يعني بختار يعني سيستميك ولا انترافيترال او سبتينال. مش عارفه حضرتك عندك
لا
كومنت؟
بالظبط، هو نفس يعني هي النقطة، بس هو يعني هي النقطة هل هو طبعا الاختيارات معتمدة على الحاجات ديت. السؤال هل واحد منهم أحسن من التاني؟ يعني let's say even compare أقوى intravitreal steroid اللي هو ريتيسيرت implant versus systemic treatment، هل واحد أقوى من التاني؟ في ستادي كويسة قوي اللي هي الماس ستادي، لقوا ان هو اكشلي لحد تقريبا 5 سنين مفيش فرق. لكن اللي بيحصل، فهو مفيش فرق في الكنترول بتاع الانفلاميشن، مفيش فرق في الفيجن. اكشلي انترفيترال ستيرويدز كنترول السيستويد ماكر اديما احسن. لكن المشكله اللي بيحصل بعد كده، وده لقوه في اكستنشن 7 سنين للاستادي، لما جم بصوا على العيانين اللي كانوا في الاستادي وخرجوا من الاستادي كريتروسبكتيف اكستنشن، لقوا ان العيانين اللي خدوا سيستميك ميديكيشن they did better. لان مشكله الانترفيترال ستيرويدز اللي بتحصل ان الناس ما تبقاش عارفين تحط امبلانت تاني امتى، هل تستنى لما يفلير اب دان ياخد امبلانت تاني ولا لا، هل يحطوا ريتيسير تاني ولا لا، هل تدي اوزردكس تاني ولا لا. فالكومبلاينس والتريتمنت احسن مع السيستميك، لكن فعليا الاثنين كومباربل مع بعض. لكن وات هابنز ان الانترفيترال ما بقاش واضح قوي يتاخد امتى، هل يتاخد بس لما تفلير اب ولا لا. فهي دي كانت
والكوست برضو،
النقطة.
الكوست برضو فاكتور.
اه طبعا الكوست، الاوكلر توكسيسيتي. فهي يعني was very useful data من retrospective extension بتاعت العيانين اللي كانوا في الماست ستادي من النقطة ديت.
تمام. يعني في بقية الكويستشنز حضرتك تحب تقول
اه
لنا
كان
اجابتها؟
في السؤال التاني كان على نقطة برضو مهمة، هل ان انت يعني عندك عيان دلوقتي كنترولد، انت مدي عيانين very high dose of steroid let's say 60 مللي جرام، لو احنا فضلنا على ماشيين على 60 مللي جرام، هل ده نفس الفيجن اللي هيحصل لو العيان ده خد ستيرويدز مع ستيل سبت؟ يعني سيبنا من السايد افكتس عشان نفهم النقطة ديت. Actually yes, that's نفس الفيجن. الستيرويدز is very very effective and you could argue that Cellcept وmethotrexate they are not more effective than steroids.
exactly.
البيولوجيكس are more effective than steroids. بس الconventional are not effective the steroid. But the main aim or main use of especially الconventional immunosuppressives زي Cellcept والazathioprine والmethotrexate is steroid sparing. ان انت عشان تقلل الدوز of steroids. You can gain better vision and more control over steroids with the biologics, including anti-TNF rituximab, but not with the convention. Again, I find that يعني useful to understand ان انت انت تستخدم ليه بتستخدم ايه ليه. فده the second point. يعني أرجو إن تكون النقطة دي واضحة يعني. النقطة الثالثة إيه أحسن treatment لليوفيتك CME هو actually intravitreal steroids. Sometimes you're not really sure العيان ده ال CME بتاعته دي هترespond ولا not respond and patients on everything. Anti-TNF sometimes CME not responding to other medication they respond to anti-TNF but the most potent is intravitreal steroids. يعني if you want to like get the end of it فعيان عنده uveitic CME not responding عايز توصل what's the maximum vision هو intravitreal steroids. That's the most potent in terms of the uveitic CME, and that's also what the MUST study showed. Subtenon is good but it's weaker than intravitreal and suprachoroidal steroids, which makes sense. I mean, the subtenon it is around the back of the eye, the suprachoroid is in the suprachoroid and intravitreal is inside.
يس حضرتك عندك حق، بس يمكن هي يعني ممكن لو كنا خدنا سامبل اكبر كانت تبقى النتائج
Yeah,
مختلفة،
انه
ولو
دي
ان
دي
يعني
compare
سامبل ما كانتش
الانترفيترال
صغيرة برضو.
steroids ولا
نعم.
في في الستاي حضرتك كنت بتقولي عليها did you compare to intravitreal steroids or
يس يعني حقيقي ما كانتش يعني داتا ويل يعني دوكيومنتد قوي، بس البيشنتس كانوا بيمبروف، وكانت يعني مع العدد بتاع العيانين وفكرة ان الادميشن فور او ار والقصة دي كلها لما يبقى عندك بيشنتس كتير بتحتاج تبقى حاجة اسرع، فكانت الاوت بيشنت سبتين اسهل كتير،
yeah no
والبيشنتس
طبعا
كانوا بيمبروف، يعني هي
يعني هو
حاجات.
اسهل. I think it works. هو is just less potent. I think that was the point study. There's a study called the point study. They looked at subtenon versus intravitreal steroids as well. هو طبعا is different practice where مثلا في اماكن كتير في امريكا وفي اوروبا we don't admit patients, we just treat them intravitreal in the clinic. No, I think subtenon is very good, less risk of pressure rise as well.
يس.
ما هو ده سؤال برضو جاي لنا في الشات من دكتورة رحاب، ودكتورة رحاب practices in Scotland. ف she's asking, do you have fear of IVI steroids about glaucoma, which is
Yeah.
yes.
I think that's a good question. I like the numbers. So, intravitreal Ozurdex, you have 30% pressure rise, 1% glaucoma surgery. Iluvin, you have 40% pressure rise, 4% glaucoma surgery. Retisert, which I like and I use بس للأسف هيقف السنة الجاية, 80% pressure rise, 40% glaucoma surgery. So we tell the patients the number. There's risk of glaucoma, بس يعني it's more important to control the inflammation than control the pressure. Rather than to leave the inflammation, you will end up with pressure problems and inflammation problems.
And then she follows up her first question with another one. She says, do you give IVI steroids with glaucoma valves? So patient with an actual device in.
I think these are great candidates for intravitreal steroids, and pseudophakic with tube is the best patient to intravitreal steroids. That's what I tell them. I tell them you're ready. You're the best candidate.
She's asking, have you ever had to extract an illuven? للأسف احنا لسه في مصر ما عندناش illuven، في الريجن بس لسه في مصر مفيش.
Yes, for endophthalmitis. We had a patient, and that's actually a good one, a good study. لو انت عندك Ozurdex endophthalmitis or Illuvin endophthalmitis, whether you remove them or not. This is an interesting one. And we had one patient and we removed it. We had actually one Ozurdex, one Illuvin, and in both patients we removed it.
But so what I gather from you is that because of infection and not because of glaucoma.
Yes, I think it's in the literature as well. Because of glaucoma, you remove them. We did not need to do this. Usually if they go glaucoma, we go they go يعني glaucoma specialists, they do a tube. If they go like very high glaucoma not controlled with pressure drops.
طب دكتور احمد، انا هاخدك ستيب لورا شويه برضو علشان المستمعين. احنا اتكلمنا على التابينج وكده، احنا كل التابس اللي احنا اتكلمنا فيها دي AC tap. So if you get an AC tap and it's negative, do you ever double down؟ يعني مثلا تقول لا هو مثلا فيرال، هو توكسو، انا هدخل وراه في الفيترس. Did you ever need to do that؟
Yeah, but here viral is very unlikely. So AC tap is really very good for even for viral, like very, very unlikely. AC for toxoplasma it can be negative. And I think it depends on the suspicion. بس هو يعني the short answer لو هو AC tap negative for viral PCR is very, very unlikely it will be virus. But still can be toxo.
اوكي، ده اول سؤال عندي. تاني سؤال عندي هو حضرتك لما if you suspect a fungal endo، يعني ده برضو حاول اجمع your talk مع Hind's talk. If you suspect fungal endo, what is your preferred regimen؟
يعني التور بتاع الدكتورة هند كان رائع، أنا سمعته كله وكان هايل، والحالات was very interesting. was very interesting إن في عيانين ما لقوش السبب، لأن this is not our experience. Usually we find because immunosuppression is not enough for fungal endophthalmitis. You have to have the organism reaching the circulation somewhere. I can only recall one patient where we never found the cause, but otherwise usually we can find the cause. Uh, usually if it's زي ما الدكتور عبد العظيم كان بيقول if it's flat lesion then systemic treatment is enough. Flat chorioretinal lesion, systemic treatment is enough. If it's involving the vitreous, then we always include, or it's elevated chorioretinal lesion, then we always include intravitreal. I don't like vitrectomy in any endophthalmitis. I think the situation is very bad. The eye is very inflamed. If you get a break, you've lost the eye. بس هو I think we need to differentiate ما بين vitrectomy to control the infection و vitrectomy for problems later on, like for example vitreous haze that is persistent. This is like you have gunk in the vitreous, you need to remove it, that's fine. Or you have membranes or have a detachment. So usually we try to avoid vitrectomy as much as we can, and then but later on it's another ball game. It's the eye is quiet and you can do vitrectomy like what you want to manage problems.
And do you
That's what I
go
tend
with
to do.
systemic or intravitreal as your primary?
Systemic, and we tend to use we like fluconazole لان هو مشكله الفوريكونازول غير ان هو غالي. الفوريكونازول محتاج انك تعمل بلاد ليفلز تشوف التراف والبيك. الحاجه التانيه هو بالذات لو انت عامل بولي فارماسي وحاططه مع موكسي فلوكساسين بيأثر على البي ار انترفلز، والعيانين دول اولد. ف at the end of the day infection disease هنا which I think I agree with, most of the candida respond very nicely to fluconazole except candida glabrata and cruce, which is not common. So usually we tend to use more fluconazole systemic, and then when we inject, you inject intravitreal voriconazole. If they're not responding or if it's one of the weird candidas, then we use voriconazole.
Thank you very much. That's an excellent, excellent approach. Yani, I agree with you. I did for my fungal endo, I usually give systemic. I mean, yeah, you can supplement with intravitreal, but ما اعرفش if anybody agrees with
No,
me.
for endogenous endophthalmitis, the main treatment is systemic antibiotics. This is different from post-procedure endophthalmitis, where the main treatment is intravitreal antibiotics.
exactly. like مثلا ماشي، لو احنا عندنا systemic contraindication للاندوفتالمايتس زي مثلا a nursing mother who refuses to stop، فساعتها ماشي اوكي خلاص، احنا ما عندناش حل غير ان احنا ندي intravitreal which goes the same for toxo، برضه بندي intravitreal clindamycin. بس يعني the general is systemic. حد عنده اي اسئلة؟ حد عنده اي points to raise؟ Right. So our job here is almost done. دكتورة مي، دكتور محمد.
يعني thank you so much على التوكس الهايلة دي دكتور أحمد، دكتورة دينا، ودكتورة هند. بجد التوكس والدiscussion كانوا مش عارفين مين أحلى من التاني. بس يعني أعتقد إن محدش المفروض يغلط في الانفكشنز تاني anymore. حضراتكم كلكم قلتوا قد إيه هي مهمة to exclude، وتشرفنا بيكم النهارده، وهنشوفكم تاني اكيد يعني. حضرتكم عملتوا اداء يخلينا نطلبكم كل مره، كل شهر على الاقل مره او مرتين من كتر ما هو هايل. وثانك يو سو ماتش، وسهرناكم، احنا اسفين جدا ان احنا تعبناكم.
شكرا جدا. انا مبسوط قوي، وشكرا على الدعوة الكريمة.
شكرا جدا يا دكتور احمد.
شكرا.
شكرا يا دكتوره دينا.
ميرسي يا دكتور.
شكرا.
تصبحوا على خير جميعا.
شكرا دكتوره
باي.
هند. very nice presentation.
يس.
أيوة.
اشوفكم على خير كلكم.
ان شاء الله، ميرسي، شكرا.
باي باي.
سلام.
اوكي.